We are back with 25 PYQs for Obs and Gynae from the past 5 FMGs. You will have only 5 seconds to answer each question, which will be followed by the correct explanation of the answer. Let us know in the comment section how many you got correct. Without further ado, here's the first question.
Question 1. Which of the following is the correct sequence of vaginal discharge during puerperium? Here are the options. A. Lochia serosa greater than Lochia rubra greater than Lochia alba. B. Lochia rubra greater than Lochia alba greater than Lochia serosa. C. Lochia alba greater than Lochia rubra. D. Lochia rubra greater than Lochia serosa greater than Lochia alba. And the correct answer is option D. Lochia rubra greater than Lochia serosa greater than Lochia alba. Here's the explanation.
When the uterus is involuting, we also know that the uterus is also shedding its lining. So when the uterus is shedding the decidua, the lining which was giving nourishment to the fetus all this while, and that shedding is going to give different colors. Okay, so on the first few days after delivery, that is 1 to 4 days, you will see a blood mixed discharge. That's why it is called a lochia rubra. It is full of RBCs, and that's the bleeding in the first 4-5 days. So that is the lochia rubra, and 5 to 9 days the lochia becomes progressively pale and yellowish in color. It's mostly mucus, and that's why it's called lochia serosa. So I hope you can see that lochia serosa. I'll mark it darker here, lochia serosa. And after 10 days, mostly what you see, it is epithelial cells with the leukocytes. So that's why it is white in color. So we call it lochia alba. All right. These are the definitions of lochia alba, serosa and rubra. But remember, how long can lochia last? Up to how many days? See, by this you are saying after 10 days, so you must be thinking around 15-16 days. Actually, it can last up to 35-36 days. So that was the MCQ which came in the INICT exam. Up till 35 to 36 days also it can last, as long as even more than a month, you know.
Question 2. A woman presents with complaints of greenish-frothy vaginal discharge for 1 month. On examination, vulvovaginal erythema is noticed. On saline microscopy, motile organisms are seen. What is the most likely diagnosis? Here are the options. A. Trichomoniasis. B. Bacterial vaginosis. C. Chlamydial cervicitis. D. Candidiasis. And the correct answer is option A. Trichomoniasis. Here's the explanation.
Trichomoniasis. Trichomoniasis is caused by Trichomonas vaginalis. And it is a flagellate protozoan. It's a flagellate protozoan. So when there is a flagellum, it will cause whiplashing movements, it will cause motility. So when there is motility, there is a motile organism. That's why it causes severe irritation. Such severe irritation and severe pruritus. So the problem is, this vagina will become very red and very inflamed. Colpitis macularis. Colpitis macularis. Colpos, you know, vagina is also known as colpos, and the vagina is inflamed. So we say inflamed vagina with red macules. So colpitis macularis, and which you already know is known as the strawberry vagina. And the discharge is greenish yellow, and it is frothy. Greenish yellow frothy discharge, and again the treatment is metronidazole.
Question 3. If the division in the zygote occurs between 9 to 12 days after fertilization, which of the following twin is expected? Here are the options. A. Dichorionic diamniotic. B. Conjoined twins. C. Monochorionic diamniotic. D. monochorionic monoamniotic. And the correct answer is option D, monochorionic monoamniotic. Here's the explanation.
If the split happens after 8 days, that is 9 day onwards, then there is one placenta and one sac with two babies in one sac. Now that is what is the monochorionic and monoamniotic twin. So this is what is the monochorionic monoamniotic. So we also call it the Momo twin. Yeah, monochorionic monoamniotic, and this, which is the most common, is actually known as the MODI.
Question 4. A couple came to the clinic with complaints of infertility. On examination, her husband had gynecomastia and tall stature. What is the possible diagnosis? Here are the options. A. Klinefelter syndrome. B. Turner syndrome. C. Swyer syndrome. D. Testicular feminization syndrome. And the correct answer is option A. Klinefelter syndrome. Here's the explanation.
Male karyotype is disturbed, a 46XY. This is normal male and he has no bar body. Suppose it becomes 47XXY. Now that's the Klinefelter syndrome, isn't it? Now how do we remember this one? Go back to how I discovered a normal looking woman. Yes, a normal looking woman has two X chromosomes to give the normal femininity. Alright, and if one X chromosome is less, the femininity is less. Now this man should have only one X chromosome. We don't want femininity in a man, isn't it? Now if this man has an extra X chromosome, he gets femininity. Alright, so this girl who had one X chromosome less became short, and this man having one extra X chromosome will become a tall man. And this one did not have proper breast. This woman did not have proper breast. This man will get gynecomastia. Yes, and will have obesity of the female pattern, will have azoospermia, and will have infertility. Alright, so yes.
Question 5. A woman presented in her early weeks of pregnancy seeking MTP. The appropriate dosage? Here are the options. A. 200 mg mifepristone and 200 microgram misoprostol. B. 800 mg mifepristone and 200 microgram misoprostol. C. 200 mg mifepristone and 800 microgram misoprostol. D. 800 mg mifepristone and 800 microgram misoprostol. And the correct answer is option C, 200 mg mifepristone and 800 microgram misoprostol. Here's the explanation.
So the medical abortion, like we said, which is the hot shot question for you people, I'll tell you the technique which is mostly used in the first 7 weeks, which is 49 days, and then the 9 weeks, which is 63 days. We can do, why am I splitting this? Because this is what is approved in India. I mean, we can do, it's not that you will be penalized for doing this, but this is the time when you have 99% success by medical abortion. So that's why it is the one which is approved in India. And till 63 days, if somebody does, it is 95% success. So yes, you can do both, but the approved one in our country is the first 7 weeks. So when you're doing medical abortion, you're just giving drugs, and the woman can be at home, take these drugs, and she can have a effective 99% abortion. But she should follow your instructions. I'll come to those. So what are the drugs? We can give mifepristone, which is around 200 to 600 milligram dosage can be given. This is a anti-progestin. It's an anti-progestin. So yes, we know anti-progestin will kill the fetus. It kills the fetus, and then around 24 hours to 48 hours later also people say, my favorite is still 24 hours, and that is where it is very effective, I feel. So you can give misoprostol. Now misoprostol is given in a dose of 800 micrograms. The tablet is around 200 micrograms, the biggest tablet which I know, and 4 of them are given. vaginally. This is given vaginally, and of course the mifepristone is given orally. For best results, I am saying. See, you can give the misoprostol orally, sublingually, and rectally, but the vaginal route is best because orally it can cause a lot of gastritis, a lot of cramps in the whole abdomen, and the gut gets hypermobile. There can be diarrhea. So the best possible method to give the least discomfort to the woman is used. So mifepristone orally, misoprostol vaginally, and 200 micrograms 4 tablets are given vaginally. You know, misoprostol is a prostaglandin. It's a prostaglandin. It will contract the uterus and it expels the fetus. So this is the regime.
Question 6. When does secondary postpartum hemorrhage develop? Here are the options. A. 1 month later. B. Within 24 hours of delivery. C. 24 hours 12 weeks after delivery. D. Greater than 12 weeks. And the correct answer is option C. 24 hours 12 weeks after delivery. Here's the explanation.
And if there are some retained tissues, that is what is known as secondary PPH. Retained tissues, retained placental tissues more specifically, that causes PPH after the 24 hours. After the first 24 hours up till 12 weeks. That is the secondary PPH.
Question 7. A woman presented in her 8th week of pregnancy seeking MTP. The appropriate dosage of misoprostol administered by mucosal route would be. Here are the options. A. 200 microgram, B. 500 microgram, C. 400 microgram, D. 800 microgram. And the correct answer is D. 800 microgram. Here is the explanation.
The prostaglandins which we use are the PGE1, which is misoprostol. And misoprostol, you know, is mostly in a tablet form, and this can be given orally around 200 micrograms. It can be given vaginally. We know that we can use it for the first trimester abortions. This misoprostol, first we give the mifepristone to degenerate the fetus, to stop the fetus life, because mifepristone is anti-progestin, and to expel the fetus we give the misoprostol. So you can give it vaginally at that moment. Around 600 micrograms to 800 micrograms is given, and also we can give it rectally. So misoprostol can be used for abortions, and it's a very effective drug. It's a big time favorite drug for the induction of abortions in the second trimester especially, and yes, even in the first trimester medical abortion, the first trimester up to 7 weeks, it is almost 99% successful in giving a complete abortion in combination with mifepristone.
Question 8. A patient with carcinoma endometrium is treated with pelvic external beam irradiation to the whole pelvis. Which of the following organs is most radiosensitive in the pelvic region? Here are the options. A. Ovary. B. Vagina. C. Bladder. D. Rectum. And the correct answer is option A. Ovary. Here's the explanation.
Ovarian tumors are radio-resistant. Normal ovary. A woman with a normal ovary, suppose she had a road traffic accident and you do an X-ray of the pelvis for the fracture assessment. You do a CT scan of the pelvis, you do a surgery for that, and then you repeat the CT scan. The ovaries will get totally destroyed. 2 CT scan, 3 CT scan is more than enough to damage the ovary more than 50%. So a normal ovary, very radio sensitive. Ovarian cancer, radio resistant. Both the MCQs have come in your exams. I hope you'll remember that.
Question 9. Oligohydramnios is associated with which of the following? Here are the options. A. Renal agenesis. B. Neural tube defect. C. Esophageal atresia. D. Premature birth. And the correct answer is option A. Renal agenesis. Here's the explanation.
So what are the causes of, let's say, oligohydramnios? Now, oligohydramnios or less liker is generally associated with renal anomalies and with intrauterine growth restriction and pre-eclampsia.
Question 10. A young female has a history of spontaneous abortion. She has had amenorrhea since then. Her FSH now is 6 MIU per milliliter. Which of the following can be a cause for her amenorrhea? Here are the options. A. Sheehan's syndrome. B. Premature ovarian failure. C. PCOS. D. Asherman syndrome. And the correct answer is option D. Asherman syndrome. Here's the explanation.
Overzealous curettage, suppose you're doing it for an abnormal uterine bleeding, or you're doing it for a medical termination of a pregnancy, or in a case of a secondary postpartum hemorrhage. You know that a secondary postpartum hemorrhage is because of retained bits of placenta. And the treatment of retained bits of placenta is to do a curettage. We'll be discussing that part in obstetrics when we start that. So, if a person is doing a curettage for any of these three conditions, he may overdo the curettage, he may be very enthusiastic in doing that curettage, and he may end up doing a scarring and fibrosis of the uterine lining, and that scarring and uterine lining will cause a secondary amenorrhea. So, yes, overzealous curettage causing secondary amenorrhea, is what is known as the Asherman syndrome. Yes, Asherman syndrome is because of overzealous curettage causing scarring of the uterine lining and secondary amenorrhea.
Question 11. A 24-year-old primigravida presents with pain in the abdomen and vaginal bleeding in the first trimester. On examination, the cervical OS is closed and uterine size is normal. Gestational sac is visible on ultrasound. What is the most probable diagnosis? Here are the options. A. Inevitable abortion. B. Threatened abortion. C. Incomplete abortion. D. Complete abortion. And the correct answer is option B. Threatened abortion. Here's the explanation.
8 weeks of gestation, patient has any kind of abortion, mostly they'll present with pain abdomen and bleeding PV. Now, along with that, if the patient who's come with pain and bleeding, on a per vaginal examination, the os is closed, the external os, the mouth of the cervix is closed, and the uterine size is equal to the period of gestation.
Question 12. A 22-year-old female presents within 8 hours of having sexual intercourse and asking for emergency contraception. She says she doesn't want multiple pills and wants just one pill. What will be your advice? Here are the options. A. Levonorgestrel 0.75 mg. B. Ethanol estradiol plus levonorgestrel. C. Levonorgestrel 1.5 mg. D. Desogestrel 3 mg. And the correct answer is option C. Levonorgestrel 1.5 mg. Here's the explanation.
Levonorgestrel 0.75 milligrams. We used to give 2 tablets. Nowadays this also became a question, I don't know why. Nowadays there is 1 tablet of 1.5 milligrams. So either way the dose is the same. Now how does this work? Suppose the woman had intercourse on the 11th day and she comes to you on the 12th day and says, "Doc, please save me, I don't want to have this child, I don't want to conceive." So she's only had intercourse and she says, "Doc, save me." So yesterday was the 11th day and she'll ovulate only on the 14th day. But I know that the sperms can live up to 3 days in the genital tract of a woman. So 12, 13, 14. The sperms will be alive on the 14th day, and if she ovulates on the 14th day, she can still get pregnant with this 11th day intercourse. So yes, what do? Yesterday she had intercourse, 11th day, today she comes to me, I give her levonorgestrel. What is levonorgestrel? It's a progesterone. What is the purpose of LH? Remember those two punchlines? Purpose of FSH, estrogen. Purpose of LH, progesterone. So you've given progesterone already. Yesterday intercourse, 11th day, 12th day you've given the progesterone. So yes, this will reduce the LH and that will reduce the ovulation and pregnancy won't happen. So that's the mechanism. that it can stop ovulation.
Question 13. Which of the following is not an absolute contraindication of the IUCD?
Here are the options. A. Undiagnosed vaginal bleeding. B. Suspected pregnancy. C. HIV-infected women. D. PID. And the correct answer is option C, HIV-infected women. Here's the explanation.
What are the contraindications of using IUCDs? You will not give IUCDs if she is pregnant or she is having puerperal sepsis, or she is having some sexually transmitted disease or pelvic inflammatory disease, or she is having undiagnosed vaginal bleeding, or they are very gross uterine anomalies, or she is having some cancers like cancer of cervix or cancer uterus. So, whenever a patient is having undiagnosed bleeding, don't get confused. As a dictum, undiagnosed bleeding, do not give IUCDs. But we also know that levonorgestrel IUCDs are given for treatment of bleeding. You should know what is the cause of bleeding first. So, yes, IUCDs as a absolute contraindication when the bleeding is not known, because what is the most common side effect of IUCD? It is too much of bleeding. So, obviously, you cannot give when a patient is bleeding, you cannot give an IUCD. Okay. So, these are the contraindications. Of course, there are quite a few minor ones also, but remember these.
Question 14. A 14-year-old girl brought by her mother with complaints that the child has not even menstruated once. On examination, secondary sexual characters are seen in uterus and ovaries were seen to be normal on USG. What is the next step of management? Here are the options. A. Combined oral contraceptives. B. Karyotyping. C. Reassure mother and patient. D. LH, FSH level and TSH. And the correct answer is option C, reassure mother and patient. Here's the explanation.
If there are no periods, till 13 years, if there are no periods, we call it delayed. And if there are no periods, but pubarch has happened, pubic axillary hair, I'll just write pubic hair in this place, pubic hair is present, then we say delayed at 15 years. So, without pubic hair and axillary hair, it is 13 years, and with pubic hair and axillary hair, we can wait another 2 years to call it a delayed cycle. So, if there is pubic hair and axillary hair and there are no periods still, then at 15 we say it is delayed cycle.
Question 15. A 45-year P3L3 woman presented with a lower abdominal mass and lower abdominal discomfort. On examination, the uterus appears uniformly enlarged and the adnexus is free. MRI shows the presence of a myometrial cyst. What is the most probable diagnosis? Here are the options. A. Endometriosis. B. Adenomyosis. C. Leiomyoma. D. Endometrial hyperplasia. And the correct answer is option B, adenomyosis. Here's the explanation.
Adenomyosis. Adenomyosis is different. In adenomyosis, the blood which is generally forming in the uterine cavity, with repeated deliveries, the uterus enlarges with a pregnancy, then it retracts and contracts, then it enlarges again and then it contracts. So, with repeated enlargement of the uterus, the endometrial and myometrial interface is disrupted. So, this blood may find its way into the uterine muscle like this. So, when the uterine blood finds its way outside the cavity, it is endometriosis, isn't it? But no, it is not outside the uterus, it is within the uterine muscle. So, then we say it is endometriosis within the uterus. That is why we call it endometriosis interna or adenomyosis, where the blood is outside the cavity but within the uterine muscle. So, if you see a picture, I think this is that picture which I have shown you in some test and discussion also. See this one. See, if you see the cut surface of adenomyosis uterus, you slice through the uterus and this is the uterine cavity here. If you see, this is the uterine cavity, it is split. You know, the uterus was like this and you made a slit through this, and now this is the cavity which is in two parts. Half of the cavity is this side and the other part is this side, and see the muscle, see the amount of muscle in this uterus. This is what is typically called a myohyperplasia, and you will see lakes. See, these are the lakes of endometrial blood. So many times when we do a hysterectomy for adenomyosis, when we cut the uterus, we see this small pinpoint lesions or slightly bigger than that, around 2 millimeters type lesions. When we cut them with a blade, you see menstrual blood coming out of those. So this is how this adenomyosis looks like. So yes, this is seen in multiparous women around 40 years or so, and it is 30% of the hysterectomy specimens, and this is associated with menorrhagia. Classically comes with menorrhagia. This is the MCQ which keeps coming, plus something called progressive dysmenorrhea. Now this is very typical definition given by Shaw's Gynecology, progressive dysmenorrhea, and a lot of gynecologists like to use this term progressive dysmenorrhea. That means you are already talking in terms of adenomyosis. So yes, the problem with adenomyosis is that you can confuse the symptoms. You know, menorrhagia, dysmenorrhea is also seen with fibroids, but the classical thing which distinguishes this, that a uterus which is uniformly enlarged but not very huge in size, as compared to a fibroid. It can be irregularly enlarged, it can go as high as to the umbilicus or even above. So fibroid can be as much of size, it can it can fill the whole abdomen also. So fibroid can be huge in size, and irregular bosselated fibroids can be seen on a uterus, but this uterus in a case of adenomyosis is uniformly enlarged.
Question 16. Spermicidal cream which is used in contraceptive. Here are the options. A. Gossipol. B. Nonoxynol 9. C. Centroman. D. Clomiphene. And the correct answer is option B. Nonoxynol 9. Here's the explanation.
It is the sponge of nonoxynol 9. It's known as Today. This sponge is put into the vagina, can be put just before intercourse, and it works for 24 hours. So this sponge has nonoxynol 9. So this is a spermacidal. This is spermacidal, and if this sponge is inserted, say tonight, then the person can use this up to 24 hours, so that even if there are multiple acts of intercourse, she doesn't have to remember to take a diaphragm or to wash the diaphragm and use it again, or think of wearing a female condom, or the man also doesn't have to remember to use it. So this is the sponge which is used as a convenience.
Question 17. Testosterone secreted by. Here are the options. A. Leydig cell. B. Sertoli cell. C. Theca lutein. D. Granulosa cell. And the correct answer is option A. Leydig cell. Here's the explanation.
So in spermatogenesis, we know that the gonadotropins, the FSH and the LH, both will play a role. You know that both the gonadotropins come from the pituitary after the stimulation from the gonadotropin releasing hormone. So the LH will act on the Leydig cells, and the FSH will act on the Sertoli cells. So right from my class 12th, I remember like the FSH, S for Sertoli cells, and LH for the Leydig cells. That's how I remembered. So I'm sure you know it even otherwise. So what happens that the LH acts on the Leydig cells to make the testosterone, and this testosterone is used by the Sertoli cells to make the mature spermatozoa.
Question 18. A 32-year-old lady with uterine fetal death after normal vaginal delivery continues passing urine from the vagina. What is the most probable diagnosis? Here are the options. A. Bladder rupture. B. Vesicovaginal fistula. C. Urge incontinence. D. Stress incontinence. And the correct answer is option B. Vesicovaginal fistula. Here's the explanation.
Alright, so vesicovaginal fistula, I get a little emotional because I've seen a lot of patients getting neglected so many times. So yes, the presentation is constant dribbling of urine, and because of the dribbling of urine, the vulva and the thighs are sodden, they are wet and they are moist thighs. So the vulva and the thighs are having excoriations because of those, that wetness between the thigh and the vulva, and these the moist thighs, when they rub against each other or rub against the vulva, that will cause some skin to get excoriated, and on that excoriation, if the urine dribbles, will cause that typical burning, which is known as the splash dysuria. So they can be excoriations, they can be a splash dysuria, urinary tract infections.
Question 19. A 26 weeks pregnant female presented with HTN for the first time. There is no proteinuria. Diagnosis of such a condition. Here are the options. A. Chronic hypertension. B. Eclampsia. C. Gestational hypertension. D. Preeclampsia. And the correct answer is option C, gestational hypertension. Here's the explanation.
When would you call a woman hypertensive? We would call her hypertensive if the blood pressure is increasing after the 20 weeks. So after 20 weeks in a previously normotensive woman. And the blood pressure should be more than 140/90 on more than 2 occasions, which should be more than 6 hours apart. Yes, a lot of women would come to the hospital and see a new doctor and a new surrounding and might get a little worked up, and the blood pressure might go up a little bit.
Question 20. Minimum sperm count concentration for normal semen analysis according to WHO. Here are the options. A. 2 million per milliliter. B. 5 million per milliliter. C. 10 million per milliliter. D. 15 million per milliliter. And the correct answer is option D, 15 million per milliliter. Here's the explanation.
So semen analysis by the WHO 2010 values, it says that the pH of the semen is alkaline, around 7.2. Basically, you should remember that the prostatic secretions are acidic, and the seminal vesicle, these secretions are alkaline. So there's a balance between the acidic and the alkaline, and the net effect is a mild alkaline pH of the semen. So what is the volume of semen? It should be at least 1.5 ml or more than that. The concentration should be more than 15 million, 15 million sperms over per ml of semen. Look, semen is different from sperm. Semen is what comes out in the ejaculate. Semen has prostatic fluid. It has got seminal vesicle fluid. The majority, 70%, yes, 70% of the constituent of semen is actually seminal vesicle fluids. So yes, that seminal vesicle fluid and prostatic fluid also in the ejaculate will be accompanied by sperms. So sperms are part of the semen. Okay, so in that semen the volume should be at least 1.5 ml, the pH should be 7.2, and concentration should be more than 15 million per ml. The count should be at least more than 39 million. Now that's a vague value hitting at 39, but yes, the reason behind this is that the normal range is 36 to 42 million. So if that range is seen, then the mid value is 39, and the motility should be more than 40% should be motile. In fact, in this 32% and more should be active motile. And morphology, at least 4% sperm should be normal. That is the strict criteria by Kruger's strict criteria, a very famous scientist who worked in andrology. Kruger's strict criteria says that if you see the sperms very closely with the head, neck and the tail, there would be defects in majority of the sperms. So as low as 4% and more, if this many sperms out of 100 are normal, then we say the man is good to have a conception in his wife. So more than 4% by the strict criteria of Kruger, if that is there by the strict criteria, so 4% and more also is a good morphology. Now, what is the next parameter which is important? And that is the pus cells. Now, pus cells should be less than 1 million over 1 ml. Okay, not more than 1 million per ml. And vitality more than 58% sperm should be live.
Question 21. Pearl index is used to calculate. Here are the options. A. Accidental pregnancies. B. Population. C. Fertility rate. D. Abortions. And the correct answer is option A. Accidental pregnancies. Here's the explanation.
Failure rates are described by the Pearl index. And you know the Pearl index is the total number of accidental pregnancies because of failure of the conception, obviously, divided by the total months of exposure. Multiplied by 1200.
Question 22. Most likely to be associated with vaginal pH of 4.5. Here are the options. A. Atrophic vaginitis. B. Trichomonas vaginatus. C. Candidal vaginitis. D. Gardnerella vaginitis. And the correct answer is option C. Candidal vaginitis. Here's the explanation.
Vaginitis. You know that vaginitis is just the inflammation of the vagina, and the pH of the vagina is acidic. The acidic pH of the vagina is around 4.5, and that acidic pH shows candidiasis.
Question 23. A 22-year-old woman presents to the doctor with complaints of irregular cycles for a few months. Her cycles are 35 to 45 days long, lasting for 3 to 4 days with mild to moderate blood flow. There is, however, no passage of clots and no dysmenorrhea. Which of the following accurately describes this condition? Here are the options. A. Amenorrhea. B. Oligamenorrhea. C. Polymenorrhea. D. Menorrhagia. And the correct answer is option B. Oligamenorrhea. Here's the explanation.
Length of a menstrual cycle, 28 days, but I would want to give you a range, 28 plus minus 7 days. So a cycle of 21 days is normal and a cycle of 35 days is also normal. But yes, this is the upper limit. Okay. If it is lesser than even 21 days, that's too frequent a period, then I say it's a polymenorrhea. And if it is even more than 35 days late, then we say it's an oligomenorrhea. Okay. Now, what is the duration of bleeding? Duration of bleeding is something like 3 to 4 days, 5 days. I would want to give you a range again, 2 to 7 days. So if it is less than 2 days, that's too less. We call it a hypomenorrhea. And if it is more than 7 days, then I call it a menorrhagia.
Question 24. Cutoff point for 50-gram glucose challenge test at 1 hour mg%? Here are the options. A. 100. B. 140. C. 180. D. 200. And the correct answer is option B. 140. Here's the explanation.
You know, the glucose challenge test, the woman was non-fasting. She was non-fasting and we gave her a challenge, GCT, glucose challenge test. So she comes to me in the morning, she's had a breakfast, and at that time I say that, okay, I'll throw a challenge of, let's say, 50 grams of glucose, and let's see if you can digest this 50 grams of glucose, and your sugar should not go very high with this challenge, with this load. So I gave her she's a non-fasting woman, and I've given her 50 grams of glucose, and values after 1 hour should be less than 140. Now, if they're more than 140, then I have a doubt. Is it a gestation diabetes mellitus? Then I have to do a confirmatory test.
Question 25. Ed. Expected date of delivery is calculated by. Here are the options. A. Young's rule. B. Nagel's formula. C. Cardiff formula. D. Hadlock formula. And the correct answer is option B. Nagel's formula. Here's the explanation.
Expected date of delivery is what we say is 40 weeks of gestation. So suppose a woman had a LMP, I'll just give you the example, which is very easy to understand. Suppose the last menstrual period of a woman was 1st of December 2022, and suppose today is 10th of January. So what is the expected date of delivery? That is given by the Naegeli's rule. All of you know that it is 9 months plus 7 days. So expected date of delivery for 1st of December, that is you add 9 months from December, that is January, February, March, April, May, June, July, August, September. So September 1 plus 7 days. So 8 September 23 is the expected date of delivery. Now, some of you get confused. You say, sir, if you subtract 3 months, what happens? See, the year is 12 months. 12 months in a continuity, that it keeps happening. 12 months will go on coming in a circle, right? So if you add 9 months, you'll reach September. If you subtract 3 months, again you'll reach September. See, December, and you subtract 3 months, you'll come to November, October, and September. So when you reach 1st September, you add 7 days, it is again 8 September. So don't get confused that, sir, if you add, it is 9 months and 7 days. But if you subtract 3 months, is it adding 7 days or subtracting 7 days? You people just keep getting confused for no reason. It is just a convenient thing to subtract 3 months to reach to September. Rather than adding 9 months, you just subtract 3 months, you'll still reach September. Anyway, you have to add 7 days, all right? So don't do any mistakes there. Now, LMP is this, and the expected date of delivery is 8th of September, that is understood. What is the period of gestation? Suppose on 10th of January 2023, what is the period of gestation? So, period of pregnancy, gestation age is also calculated from the first day of the LMP. Don't get confused. Yes, you and me know that when a woman is menstruating, she is not pregnant. But all pregnancy durations are taken from the first day of the LMP. Please understand that. That's a very important fact, because the egg starts growing on the first day of the period. So when the egg starts growing at that time, so gestations are also taken from the first day of the LMP. So please go and see the chapter on menstrual physiology. I've explained this in great detail. The egg starts growing in the first day of the menstrual cycle. That's why all gestational ages are taken from the first day of the LMP. So LMP is 1st of December, and suppose today is 10th of Jan. So how many days of December? 30 days of December were left, plus 10 days of January. This is equal to 40 days of pregnancy. So if it is 40 days of pregnancy, you divide by 7. 7 5s are 35. 5 weeks plus 5 days. That is the period of gestation. So this is how you calculate the period of gestation.
Join us tomorrow for part 2 of Obs and Gynae, where we'll cover another set of questions which can be a personal mock test. Don't forget to like and subscribe if you learned something new. See you then.